Thank you. Thanks to Dr. Lalitama, thanks to the team for having me here to discuss something more on the ophthalmic trauma research. After being in India for some time, and when I moved to Singapore, I've started some work on ophthalmic trauma research and how do we move it forward. And I'm glad that on this last day, there are still a lot of delegates and faculty members here to attend this talk. Basically, no financial disclosure. Let's move on to the very simple topic of we proposed a classification of ocular trauma that's been years old and possibly a couple of decades old. But there has never been any kind of serious changes in how do we look at the trauma and how do we look at the trauma classification. It's basically based on three important variables, wherein we have initial visual acuity, and we try to grade a lot of trauma patients based on the initial visual acuity. Then we always try to see relative afferent pupillary defect, and based on that, a lot of people take a decision about whether this eye will do well or not. And likewise, we do based our decision based on location of the wound, anterior to the limbus, posterior to the limbus, and zone 3 injury. What it helps us, the classification, as like most of the other classification for diabetic retinopathy or macular degeneration, is to give a common talk between the two ophthalmologists when we are referring. It prevents ambiguity in communication and also helps us prognosticate outcome in some of these patients with open globe injury, and based on if we try to apply this ocular trauma score, which unfortunately has not been widely used except for research. Let's put across our thoughts on what do we do with this trauma classification. It takes into consideration only the mechanical eye injuries, does not take into consideration what Dr. Grover very elegantly pointed out, the lid and adnexa. I think besides cosmetic, it has got more of prognostic value also, and we'll talk about it soon. Visual acuity given plenty of significance, and do we rely our management basically based on the visual acuity? RAPD, is it definite, and have we not seen the papers where the RAPD has been reversible, and shall we just take our decision based on the relative afferent pupillary defect? Zone 1, it does not define us. Everyone says zone 1 is good, but there are a lot of wounds which pass through the visual axis. Is there a need to divide those zone 1 into further subclassification or subgroup? And does not take into consideration at all about the intraocular pressure, which has been a totally forgiven thing where people are not even looking into what is the pressure after the trauma or before immediately in the long run. And then landmark of zone 3 has been very ambiguously or very without any rationale has been defined as 5 mm posterior to the limbus. Now, what does exactly this 5 mm behind the limbus mean? We published a couple of papers based on these controversies evolving around ocular trauma and also about the traumatic cataract. Let's talk about some of this controversy, wherein the first one is the zone 3 injury classification. And in the conventional classification, we have zone 3, anything which is going beyond 5 mm of the sclera. And then it says zone 3. By zone 3, you mean that it's possibly will not do very well. And we attempted to look into what is the rationale behind zone 3. And here, as you can see, I try to divide this, anything which is going beyond the limbus. Zone 3, there is still a skirt of sclera which is remaining in the lateral rectus of 1.9, superior rectus 2.2, 0.5 in the medial rectus region. So this still comes into the zone 3, but that's anterior to rectus. Does it do very well, that part of zone 3? And went into one of the publications from Duens also, where they said the spiral of Tillux also corresponds to pars placata inside, and that can affect the outcome, basically based on the muscle insertion. I did we attempted to do a classification based on this, where zone 3A and zone 3B, anything which was within the zone 3, anterior to rectus insertion was zone 3A, anything beyond the rectus insertion was zone 3B, and where we've seen that anything which is beyond rectus insertion does not do very well, and which is anterior to rectus insertion will do possibly well. But it's a very small case series of 26 cases. And do we really need to look into this definition? And we had a discussion with Professor Kuhn himself, and I could not get a very convincing answer about what was the rationale behind putting that landmark as zone 3 injury. So I think that need to be possibly relooked into, and we need to have a better classification system as far as prognosis is concerned. Second thing, controversy, surgical treatment of severely traumatized eye with initial visual acuity. I think a lot of us have moved aside from this, and a lot of us still repair even if it's a no light perception. But just to share some of the facts and some of the things which we published also is in the near no light perception, we have seen, and 33% of the eyes recovered ambulatory vision, if not the complete vision, but they recovered ambulatory vision. So I think as we are practicing here out in India also and a lot of other parts of the world, that no light perception is strictly not an indication for primary enucleation or primary vision. It's a very strict no, and just not because of risk of sympathetic ophthalmia, because that's a very trivial risk and still very well manageable by current immunosuppressive agent. So I think no light perception should not refrain you from not doing open globe injury repair, and there is a good amount of literature available to support that. Now, as Dr. Gurwar pointed out, lid and adnexa, does it have any prognostic significance? Shall we need to put it into a classification system? And I think we have Dr. Ganga here also, who has been also strongly propagating about the lid and adnexal trauma, and we have been trying hard to put this ocular trauma into ophthalmic trauma with inclusion of lid and adnexal trauma. Then there are plenty of literature out there where they have shown a lid and adnexal trauma can be associated with poor outcome. And Professor Michael Grant from Johns Hopkins, he created a nice model in 2008, I think, where he proposed this lid associated lid involvement can lead to a poor outcome. And that's the scientific rationale about that is whenever the lids are involved and the globe is involved, probably the severity of trauma is quite high, quite severe, and then it can lead to a poor prognostic outcome as compared to we just don't involve that in the classification system. Now, RAPD, as we have spoken about, there are good literature available where we have seen the RAPD which was present initially was reversible, and we also try to look into our series where we try to put that into multivariate analysis. You see, it's not that of significance as against some of the other variables which can be present, and therefore it possibly does not require that much of significance as the importance has been given in the current classification system. Now, ophthalmic trauma surgery training, this is the last bit of it. Just take a couple of minutes more. For cataract, any training center, including best centers, you need to have certain amount of surgery before you can move on to SICS or before you can move on to phaco. Femtosecond surgeon, possibly you are the head of the department, then only you can do femtosecond surgery. Cornea, retina, glaucoma, oculoplasty, you need to have certain amount of training before you can do that. But for trauma, you enter into training program, you are certified to do a trauma. You will be the first day, you will see yourself in the trauma. Does it not require any kind of training? We try to put this question into our recently published article also, but I think a lot of places across the world does not require a resident to be trained in trauma, and first day onwards he is certified, qualified to do open globe injury repair, which has got a very good outcome. So I think if I can put one take home message from this thing is that I think the trauma thing require more attention to prevent outcome like this. So if you have the basic principles right, and we are trying to put through all the trauma courses, which takes a very last course in all the meetings, but I think this is the message which we like to try to put on. The international eye injury registry is not existing. We are not ready to put that. We are focusing on the diabetic retinopathy, macular degeneration also, but I think this also requires a lot of attention. Thank you very much for your patience. So that was